Eating disorders by Professor Amianto. Hello, sir.
Hello,
it's
good
nice
morning.
to see your face. It's you. We have your voice. Okay, I think you should have access to share your screen. You can start whenever you're ready.
Recording in progress.
And also, before you start, I just wanted to get permission of whether it's okay to share the video of your lecture on YouTube and also to share it with the attendings after it is done.
Okay, there's no problem.
Okay,
I only try to open my slides. Okay.
Okay.
I cannot see the slides.
We still don't have your slides. I think you should use the share screen option. And then instead of uploading a file, you can.
Well, the share is this one, but I only see the main screen and I don't see the slide screen. I believe that I have to make the same of the previous.
If you tap on the entire screen and then go to your slides, we will see your slides, I think. Right now, because you're in the Zoom page, you're seeing and we're seeing your Zoom page, but once you switch to the slides, we will also be seeing the slides.
I don't know if I understood. I have to close the page of Zoom, you say?
No, not close it. There is a green icon at the bottom that says share.
Yeah.
When you tap on it.
Oh, okay. I was able.
Okay.
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 Well, today I thank you for your invitation and greetings to all participants because I'm very proud and very honored to be here to speak about the suicide in eating disorders. Suicide in eating disorders is a very great problem, a very huge issue for treatment for clinical management of eating disorders, especially after the COVID-19 pandemics. The rate of suicide and suicide ideation, especially in adolescents with eating disorders, is grown up and has become a major problem. But in general, literature demonstrates that suicide is the second cause of death for anorexia nervosa. That is very high rate of suicide, similar to that of depression, and is also a main problem for bulimia nervosa and binge eating disorder that are often not considered in this kind of problem as a possible cause of death, but because of suicide, they become a relevant cause of death. All the reviews on suicidality try to respond, to explain why there is so high risk for suicidality in eating disorders. The eating disorder itself, especially anorexia nervosa, is a sort of a delayed mean of suicide. So it's a problem that is within the psychopathology of the eating disorder itself. The rates in the USA of suicide are very high. In anorexia nervosa, the 25% has an history of attempted suicide. And this is with a difference between the two subtypes. The restrictor, anorexia nervosa, has a 16% rate of suicide, while the bulimia binge purging anorexia nervosa rises to 44%. That is quite one half of people with an attempt of suicide in a lifetime. While in bulimia nervosa, the rate is 31%, and in binge eating disorder, the 23%. The relative risk is so very high, more or less the 5 folds for anorexia nervosa, 6 folds for bulimia nervosa, and more or less 5 folds for binge eating disorder. This means that the suicide is a major problem also with concerns in hospitalization. Patients that are hospitalized because of an eating disorder generally have a high percent of a high rate of suicide attempt that is greater than the general population of eating disorder people. And also when we studied students that are a risk population for eating disorders, and it's assessed the rate of eating disorder, depression, and suicide risk. It's evident that anorexia nervosa has a 7% of symptoms related to suicide, and bulimia nervosa at 29% of rates of suicide. There are some predictors of suicide in the eating disorder population. For instance, in this study, the diagnostic category was a very strong indicator of suicide risk. The history of self-mutilation, the NSI, the non-suicidal self-harm, is a risk of suicidal actions. The hospitalization is a risk factor. The coexistence, the comorbidity of depression is another risk factor, and also the disorders of impulse regulation that are strongly linked to the borderline personality disorders. In the anorexia nervosa, there are also specific indicators that are high levels of anxiety, high levels of depression, and the greater BMI. In the bulimia nervosa, they prevail hospitalization, self-mutilation, depression, and the duration of illness with poor emotional control, poor impulse control. This links the risk of suicide to personality functioning in eating disorders. Eating disorders have been highly assessed with personality assessment instruments because the outburst of eating disorder is strictly linked to some kind of personality trait. For instance, perfectionism, obsessive compulsive traits, neuroticism, negative emotionality, harm avoidance, low self-directedness, low cooperativeness, and avoidant personality disorders are strictly related to anorexia nervosa and to anorexic functioning, and they are also in some way a risk towards suicide. In particular, there is a trait, it's the trait of persistence. The high persistence has been related by many studies to the risk of suicide, because to commit suicide, a person has the need to overcome the self-protective instincts, and so the existence of this trait that puts the person in the attitude of persisting in their attempts to overcome their protection, their self-protection, puts the person at a higher risk of being of committing suicide. In anorexia nervosa, there are also other traits that may be related, especially in binge purging anorexia nervosa, like high impulsivity, sensation seeking, novelty seeking, and in general borderline personality disorder that are also present in bulimia nervosa. Bulimia nervosa is the more impulsive eating disorder, in which they are more expressed the personality disorder, such as borderline personality disorder. In reality, the literature doesn't present a very high rate of personality disorders in the group of the eating disorder. The full diagnosis of personality disorders is only the 22% in anorexia nervosa restricting type, in which the obsessive compulsive personality disorder is the more represented. while in anorexia nervosa and bulimia with binge purging type, and in bulimia nervosa, the most represented personality disorder is the borderline personality disorder, which is present in the 25% in anorexia nervosa binge purging and 28% in bulimia nervosa. This means that only the personality traits, even without a complete diagnosis of personality disorder, are possible actors, are possible risk factors for impulsive and self-damaging behaviors in these eating disorders. From a clinical point of view, what we have seen in this study is that, for instance, the presence of some personality traits that are mainly the low self-directedness and low cooperativeness, that mean a low maturity in character, personality functioning, are related to self-harm, not suicidal self-harm. This means that these traits that are not personality disorder itself are strictly related to one of the major risk factors for suicide, and with one of the most diffused tendency in especially in the adolescents with eating disorders, that is self-harming. Another trait that has been studied recently is the narcissism. Narcissism is a strong personality trait that is not necessarily related to narcissistic personality disorder as diagnosed by DSM, because it's a psychological construct and not necessarily related to grandiose personality disorder as the DSM describes. These narcissistic personality traits are very relevant for the outcome and for the attitudes, the destructive attitudes of anorectic people towards themselves, and is also a negative prognostic factor towards the outcome of the anorexia nervosa, because it fosters resistance, treatment resistance towards psychotherapy, resistance towards the request of the clinicians, and is also in itself a risk for suicide. The previous speakers evidenced that not necessarily suicide is a medical issue, is a mental health issue, but is very relevant that suicide often is stimulated or is permitted by certain personality traits, even not medically expressed, even not diagnostically expressed personality traits that can be at the basis of this kind of reaction towards the stress that the person can perceive in the external world. Then there is another issue that is the basis of the functioning of personality in the eating disorders. In the eating disorder, especially in anorexia nervosa, since the 80s of the last century, is well known that there is a sort of a disorganization of the structure of personality. This is not coinciding with the personality disorder itself, but it means that personality of anorexia nervosa is not completely formed and is not prepared to overcome adolescence. And this is the reason, because probably eating disorders are expressed mainly in adolescence, and imply the need to overcome adolescent issues such as attachment issues to solve to heal from the disorder. And Hildebroek is one of the most important of these researchers, of these clinicians that in the last century evidenced this deficit in the self-organization, in the personality organization, especially in anorexia nervosa. And recent research on neuroscience evidence that there are many alterations also from a structural point of view in the brain of people with anorexia nervosa that are very linked to the possible deficits in the self-organization of people with anorexia nervosa. And this deficit in self-organization may represent also a risk factor for suicide attempts and suicide behaviors in general. Then I present a research that we performed on people with eating disorder that are included in patient treatment in a hospital, in a child hospital here in Turin. And I will present the differences, the different patterns of psychopathology and personality traits among these people with suicide ideation, suicide attempts, and not suicidal self-harm. The basis of this research is that the psychiatric psychopathology, and especially the eating disorder psychopathology, has risen a lot after COVID-19 pandemics. And in particular, the eating disorders are the need for treatment, for inpatient treatment of the eating disorder is raised a lot, because it's raised until the 100%, that is doubled with respect to the period before the pandemics. This because the psychopathology and the comorbidity and also the suicide attempts in this population are greatly worse, and also suicidal ideation and the NSSIs have been underwent a great increase after the pandemics. This probably because of a worsening in the general functioning of adolescent personality and organization of the self. This obviously imposed problems and imposed strategies, management strategies to increase the safety of the patient within the pediatric hospital, especially when the patients were not put in the neuropsychiatric ward, but they were collocated, they were put in the pediatric, general pediatric wards because of the greater number of these inpatient treatments. The research included 85 adolescents with anorexia nervosa who were admitted to the child hospital of Turin, and where all these 81 adolescents were assessed with personality traits, eating disorder, attachment, and also family functioning. And this assessment was done with self-administered instrument, but with instruments that are standardized and recognized internationally, so to grant a uniformity of assessment and also a scientificity of assessment. And they were compared, those who exhibited the risk behaviors compared to those who did not. And these psychopathological traits were also correlated to the discharge procedures and the duration of treatment. The included patients were all female, 79 were affected with typical anorexia nervosa and 6 with atypical anorexia nervosa, with a BMI range from the very severe 10 of BMI range, kilogram per square meter, to 23. With these clinical parameters, the mean age was around 15 years. The length of stay in hospital was 46 days. The BMI at admission was in the mean 15.7, and a discharge 16.3, with an increase, a medium increase of BMI. Well, what were the characteristics? Only 2 people among these adolescents had attempted suicide, and fortunately they were not able to suicide. But they were largely different from the other people who were were put in this inpatient treatment. They had generally a reduced length of stay because they are rapidly moved to the child neuropsychiatric hospital, neuropsychiatric ward, but they expressed impulsivity, anticipatory worry, interpersonal distrust, preoccupation for relationships, difficulty in describing feelings, and in general, a worse family functioning. These are all traits that put these 2 people at risk of suicide. 18 patients were characterized by ideation, anti-conservative suicide ideation at the time of the admission in the ward. They were characterized by greater BMI at admission, greater BMI at discharge, phobic anxiety, worse paternal care, worse paternal overprotection, worse functioning of the family as concerns problem solving, emotional involvement, and general family functioning. And they also tended to express the trait of exploitation, tendency to exploit other people, that is a narcissistic trait, the NPI-40, that is an instrument for the assessment of narcissistic personality traits. 16 patients engaged in an exercise, non-suicidal self-harm, prior to the admission to the ward. They were characterized by the ASQ disease for intimacy, total depression, and somatic depression, that are mainly psychopathological traits. And then 4 subjects displayed an important social withdrawal, that is highly relevant risk factor for depression and for suicidal ideation. And these were characterized BMI, PBI was maternal protection, was paternal overprotection, and again, exploitation. These traits were related, all traits were related to admission, the length of hospital stay, the BMI at admission, and at discharge. What are the conclusions from this research? Well, the first conclusion is that with a few exceptions, each risky behavior is a unique psychopathological profile that distinguishes it from the others. So, to perform suicide, to have suicidal ideation, to have an exercise, or to have a social withdrawal is different from one condition to the other. And this differentiation is very useful, is very interesting, because it represents a possibility to personalize the treatment and the approach, and also the collocation of the patient within the hospital wards. Then, the prevalence of psychopathology risk behaviors are correlated with alteration in general family functioning and parental care. And this means that the most relevant change in the attitudes that we can reach in subjects with eating disorders that attempt suicide is to improve their parental care and their general family functioning. The risk behaviors are less related to BMI and to depressive psychopathology than to family functioning and parental functioning. Then there is a sort of continuity between psychological traits in suicidal ideation, suicide attempts, and social withdrawal. So these behaviors are not completely separate, not completely and discretely separated each from the other, but are in some way a sort of continuous, and this permits to identify the NSSI, the withdrawal, and the ideation, the suicidal ideation, as risk factors for committing suicide, as literature sustains. Then psychopathological and functional screening of the patient with eating disorder before admission to pediatric wards is a useful indicator to identify the most useful, the most secure placement for the safety and the management of the patient, and to produce an effective treatment of these traits and of this malfunctioning. And then the study of these psychopathological profiles in eating disorder patients is also relevant to personalized psychotherapeutic and preventive interventions that can be done in this very fragile population. Okay, this is all for my speech, and I am available for your questions.
Thank you very much. This was a very valuable speech. I'm waiting for people to write down their questions so that I can read them out loud for you. Does eating low-quality food like junk foods frequently also increase the rate of suicide? Is there a correlation between that?
Well, I am not prepared to this question because I do not generally, when we treat eating disorder, generally we do not see people with the attitude towards junk food, because especially anorexia nervosa is completely on the opposite side. They are generally orthorexic and they are disgusted by some junk food. Probably in obesity and binge eating disorder, there is more suitability also in bulimia nervosa towards junk food, but I believe that this is a mean of that kind of long-term suicidal ideation that is the eating disorder itself. Suicide in eating disorder is a very under traceable thought that aligns on the basis of the disorder. People with an eating disorder are aware that they are self-damaging. They are aware that their behavior is not a healthy behavior, but they continue to persist in their behavior and they are not able to stop this behavior. So also the use of junk food is a sort of is like to use a cutter for self-cutting or self-harming in some way. So it's a mean that may be helpful to produce self-damages, but is not a cause or is not psychopathological related to this. Instead, if I can, since there are not questions, I try to answer to your question to previous speaker. That was, what can we do, what can you do as person to try to avoid or to reduce the risk of suicidality? Well, my opinion is that the social support that may substitute, may replace that of the family. As I have said before, the family support is very, very important for suicidal ideation in adolescents. And I believe that also in adults, it's very relevant, the social support and the family support to reduce the risk of suicidal ideation. Because when a person has a suicidal ideation, it is towards the rest of the world, towards the nation around him, and to perceive that more need is able to communicate affection may reduce kind of a complete separation person, and there was withdrawal that means the risk of suicidal suicide is very.
And then there's also this question: suicide ideation that in situations such as a pandemic, which I kind of addressed in the answer you gave here, that community and the sense of connection can really help.
Yeah, probably this is the main reason, because many people, especially those people that were already poorly integrated in community, had this increase in suffering because they perceived a disconnection with respect to the rest of their families or friends or parents or the rest of society, and probably it increased a lot both the suicidal ideation and suicidal attempts, and also the defection in affectivity and in attachment that favored a worse construction, worse integration of the personality organization that I've said before as a main topic of the eating disorder psychopathology.
Okay, thank you. And then there is another question. Can we say the roots of self-injury in eating disorders mostly arise from anxiety and a lack of control in life, or is it different person to person?
Yes, tell you the truth, the problem of anxiety is not generally the most relevant. The most relevant is the problem of rage or tension or emotional discontrol, but with a more strict relationship towards anger and towards rage, because generally people who are going to self-cut and to self-harm are rageous, they display a worse behavior towards other people, a worse connection towards other people, and they are enraged towards other people. So they are not necessarily anxious or not mainly anxious. They are more enraged. In fact, we generally use also drugs that are able to control the rage and not to control only the anxiety, because they are not effective on these behaviors.
Okay. I don't see any other questions in the chat or the Q&A box. Thank you very much. This was a very, very interesting. Glad to have you. We will get in.
Okay. Thank you.
Have a great.
Thank you, and thanks for your invitation.
Absolutely. Good afternoon.
See you.